Okay, I think I'm going to start. We've got a great, I'm sure there'll be some people continuing to join, but my name is Stephanie. I'm with Craig's Cause Pancreatic Cancer Society, and I'd like to welcome everyone to our first session. Probably one of our most exciting sessions that we're quite excited about. It's called Patients' Perspectives, Key Findings from Canada's Pancreatic Cancer Survey. So first, I would like to introduce our team. So we have Stacy Blair. She's our executive assistant. We have Julian Fryer. He is our marketing and communications coordinator. We have Erin Ranger. She's our patient support manager. And we have Jessica Nickerson, or Macquarie now, who is just about to give birth to her baby, and we're glad that the stress of planning this event didn't cause an early delivery. So, Jessica's done a lot of work, on this conference, and, we've certainly appreciated having her along for the ride. We'd like to thank Viatris, for the unrestricted educational grant that makes a lot of these conferences and our work here possible. So once again, thanks to Viatris. The National Pancreas Conference has been offered on odd years. It is accredited through the Royal College of Physicians and Surgeons of Canada, and it's been co-developed with the Canadian Association of General Surgeons, and we had the partnership of the Baker Center for Pancreatic Cancer, which we were thrilled to have this year. So we'd like to thank all of our partners, again, Viatris, and I'd like to thank my small but mighty staff team, as we've had a very busy November and a very busy year planning this conference. So we hope that everyone takes away something from the conference and is able to use that in their practice or within their organization. So once again, thank you. And I will hand over the session to Jessica and Erin. Oh, one more thing, housekeeping. If you have questions, Erin and Jessica have divided this presentation up into the 4 sections of the survey. So after each survey section, there'll be time to either share an experience, ask a question, agree or disagree with some of the data that's presented, and ask for further clarification. So there'll be a discussion for 20 minutes, and then there'll be time to, well, maybe even like 18, 17 minutes, and then there'll be time to share and ask questions. And then once again, we'll continue to repeat that pattern of questioning and sharing. Julian will be working the chat, our communications and marketing coordinator. So he'll be able to field some questions as well in the chat. And if you have any questions that you want to share or, experiences, you can also put up your little Google. Okay, Jessica, I'll hand it over to you.
Okay, thanks, Steph, for the introduction, and thank you everyone for joining this. I really hope it's a engaging and impactful discussion for both healthcare providers, supportive care workers, advocacy representatives, as well as the patients that we're so proud to have involved with this year's event. Erin's actually going to start by opening our presentation today. She has done the heavy lifting in terms of constructing our survey, as well as recruiting all of our responding patients. So Erin, I'll move it over to you to introduce kind of the methods behind the data that we're going to discuss.
Yeah, thanks so much, Jess. Really happy to be here today. Thank you everyone so much for being here as well. See lots of familiar patients, which is really great. And so just jumping in, so we launched our National Patient Experience Survey. And the reason that we did this was because we noticed that pancreatic cancer is one of the hardest to treat cancers. And we don't often get a lot of the patient experience. We get a lot of the clinical data set, but we don't often get that actual patient experience and what they're going through. So we find that it's really important to listen to patient voices because they're sort of where change needs to start and where change needs to go. And their perspectives help guide us towards solutions that actually reflect real needs and not just assumptions. Sorry, and yeah, so they're sorry, it was our goals. So jumping into our goals. So our goals with the survey is we want to capture what patients and caregivers actually experience at every stage of the journey. So from diagnosis to treatment to palliative care to end of life potentially. We want to capture all of those sort of stages of their journey. To help us see the full pathway rather than isolated moments of care. So by mapping these experiences, we can identify where the biggest gaps exist. So whether it's a delay in diagnosis, barriers to accessing specialists, lack of information, or uneven support between provinces. So we're just trying to see, sort of where we need to improve. Our so to strengthen our advocacy work as well. So patient-reported data gives us credible national evidence to bring to policymakers, health leaders, and funders. It helps us push for meaningful system-level changes that reflect real-world needs. Our journey for recruiting responses has been quite vast. So we're reaching out to everyone. So we are using our communication networks that we have through emails and things that we have with patients and caregivers. We're using our social media. We're reaching out to healthcare providers to ask if they'd voluntarily like to share this survey. And we are using word of mouth, of course, as well. We're looking to get 500 at least responses. So we sort of need all of the recruitment we can get. And yeah, we're really excited about the survey and getting more responses. And yeah, with that said, and sorry, we are also approved through the Research Ethics Board of Nova Scotia Health. And yeah, with that said, Jess, sorry, I will hand it over to you.
Yeah, I was just trying to unmute myself.
Oh, sorry.
Okay, so yeah, as Erin mentioned, we have a lot more recruiting left to do, with a goal of 500 responses in total to get the most significant statistics and meaningful information out of this data, as well as, you know, balanced representation from all across Canada, as well as other demographics, just as much representation of patients as we can get in order to have everyone's voices heard and use this data to help standardize the way we treat this disease, which will be a big part of our discussion in the morning that I hope you're all able to join. But so far, we've been able to collect about 40 responses, which does give us a starting point, but I will say the results that I'm presenting this evening do need to be taken with a bit of a grain of salt, as our sample size is not what it needs to be in order to make really heavy conclusions. So just to break down the respondents that we do have so far, as expected, many of them are from Ontario, a few from Nova Scotia, BC, Alberta, and one from Saskatchewan, Quebec, and Newfoundland, respectively, with a pretty even split, about 50-50 between males and females. The age distribution is probably very representative of, the age of diagnosis of this disease. So most of our respondents are between the ages of 50 and 70 years old, and many identifying as white Caucasian, with some representation from Indigenous, Black, and East Asian populations as well. So the first section of the patient survey, which some of you may have even completed yourselves, looks at the symptoms of pancreatic cancer. And so here we're just looking at the frequency of each kind of common symptom that we probed prior to patients being diagnosed. So this information will really drive the awareness efforts that we use to try and educate people on early signs and symptoms that should motivate them to get into their doctor and achieve a diagnosis as soon as possible. as we know that late diagnosis is one of the main challenges with this disease. And we can see the frequency of abdominal pain is about 70% of respondents, digestive upset 60%, back pain is quite common, and then changes to stool and urine color, as well as decreased appetite. So I don't think there's any huge surprises there, but just to give an overview of the symptoms that were experienced by these patients. So another big challenge with pancreatic cancer is the elapsed time between seeking medical care to getting your referrals to having those important tests done to achieving your diagnosis and then to starting treatment. The first piece of that is the elapsed time between a patient recognizing symptoms and seeking medical help. And we can see that if we kind of break it down by symptoms, those with the most pain seem to be in their doctor's office the soonest. Abdominal pain and digestive upset and back pain seem to be the symptoms that are experienced among those patients who are in their doctor's office before the 3-month mark. Whereas a symptom that is less painful but no less important to recognize, such as unexpected weight loss, seems to leave people waiting like over the 6-month mark. And we can see if we break that down by the stage of disease at diagnosis, those that wait over 6 months, there's 75% of those patients that are being diagnosed at stage 4. So it's important that we use this information to spread awareness on the early signs and symptoms and how important it is to get into a doctor as soon as possible. So between seeking that medical help to actually acquiring a diagnostic test is another kind of elapsed time within the pancreatic cancer journey that can really influence how effectively we can treat the disease. And if we look at the data across different provinces, we can see that all 4 provinces that had more than one respondent seem to show a median elapsed time of 1 to 3 months between seeking help to receiving those diagnostic tests. And it does, again, taking these numbers with a bit of a grain of salt, there seems to be about a doubling in the frequency of patients who have the shortest wait time for this particular period between being in Ontario versus Nova Scotia or Alberta, for example, in this case. So perhaps we're not offering equitable and equivalent care just due to resources and population and all of those kind of expected factors. In terms of the wait time versus a patient's risk factor, I don't have any training in the healthcare field, so my presumptions are strictly that they're presumptions, but I did think that a patient with a family history of pancreatic cancer would kind of be moved along more quickly. But it seems like those with a first-degree relative that has had pancreatic cancer could be waiting, over 6 months to get their diagnostic tests just as easily as somebody with no family history of the disease. So I don't know if this is a good time to open the floor, but if there's any healthcare providers on that can speak to that point, and whether you would expect a difference based on family history or not based on current practices. I found that result kind of puzzling so far. But again, it's something we have to keep an eye on as we collect more responses and get more meaningful data.
I wonder if in terms of the provinces too, you're looking at Ontario has two great facilities that are
Mhm.
targeting pancreatic cancer in terms of an earlier diagnosis. And a team of professionals around those patients upon a diagnosis that are referred to, the Baker Center for Pancreatic Cancer and the McCain Center as well. So, that could be two possibilities.
Mhm. Yeah, for sure.
Is there anyone else that I don't see any hands
Yeah,
raised.
I think by provinces, it's kind of Leslie. Your
Yeah,
numbers are just so small that means nothing right now,
yeah,
because it's really hard when you only have 5 patients and a
yeah,
spread. Um,
Mhm.
it'll be interesting as you get your 500, but I
yeah,
wouldn't put that much. But you will definitely see differences between provinces and urban versus rural, depending where you live and that sort of stuff.
yeah,
um, and then the family history. Um, the incidence of familial pancreatic cancer is low. So it's not, the majority are sporadic cases. So that's also a little bit of a tough one to look at too, until you get bigger numbers. And that's a whole other conversation about how to survey first degree relatives and what's the right thing or the wrong thing to do with them.
yeah. I would see a similar comment from, I think it was Chris Pinn, maybe, stating the same thing. Would it be a suggestion? Would it be good to map this information related to the distance the patient is from a hospital? So I know that I've read research before, and they were saying that the average Canadian has to travel, I think it was 130 or 150 kilometers each way to a center for cancer, a cancer center. Just an average Canadian. When you look at how vast Canada is, we certainly have some geography challenges for many patients, especially as Dr. Leslie mentioned, coming from rural areas. So we have patients that could be traveling from Moncton to Halifax, the QE2 for surgery, and they're only traveling 3 hours, but then if you're coming from Yarmouth or different parts of Cape Breton, you're looking at 5 or, over 5 hours of travel. So even just within the province itself, you can have, a longer distance to travel than someone coming from outside the province into a different province.
Can I just add one thing? It's Ayelet. I used to work at UHN, but I'm now with Pancreatic Cancer Canada. Sometimes with the patients that we saw coming through clinic, they had no idea about their family history until they were actually in clinic and interviewed by a genetic counselor. So I wonder if some of those that were actually seen after 6 months only realized they had a family history at that point. It'd be interesting to know
Absolutely.
that too.
Yeah,
Right.
absolutely. That's a good suggestion. I just wrote that down. Is there any other one that we just don't want to miss anyone before we move on to our next section? No? Okay. Jess, you're good.
So moving on to the wait times that are experienced between, achieving your pancreatic cancer diagnosis and actually receiving treatment. It does seem like most patients are waiting over a month to get from diagnosis to starting treatment, regardless of the province where they live in. Also, regardless of the stage of their disease. So I don't know if again, this could be a discussion point that I'm interested to hear other people's insight on. If that's what you would expect, if that's something that we should be working on. I don't know if the goal should be to get those stage 2 to 3 patients like treated as efficiently as possible as quickly as possible while they're still considered, you know, possible candidates for surgery. But again, I'd love to make this a discussion and hear people's input on what you would expect for this based on stage of disease, as well as what we should be working towards.
I see Kathy Palmer. She has said, I think it might be relevant to know that year in which the diagnosis was made. When my sister was diagnosed 15 years ago in London, Ontario, the family doctor didn't think about pancreatic cancer, only stress. I would like to think that family doctors are much more aware now. Yeah, that's a hard one. And, again, we'll turn to some of the professionals that are here within the chat. And, I certainly felt that way back when my father was diagnosed as well, and that was 19 years ago. However, when you look at the amount of cases of pancreatic cancer within Canada and the amount of GPs that where patients may first present, if they even have a GP, you're looking at a GP may see a pancreatic cancer patient maybe 5 times within their career. So, you certainly don't see the same number of pancreatic cancer patients in your career as a general practitioner as you would a different disease. So I feel like with the addition of the symptoms being so vague, we're still struggling with a lot of misdiagnoses. And then also along with the staging of the disease, we've seen and certainly read a lot of research out of Canada as well that somewhere, depending on the province, upwards to 60% of metastatic patients, so when we're talking about the stage of the disease, often aren't offered treatment or told about their treatment options. So we're struggling with, I think, the stigma of pancreatic cancer. And I think we're struggling with whether patients in Canada even have a general practitioner. I know for one that my family just got one recently. And then we're struggling with, the awareness for family physicians. Will they recognize a pancreatic cancer patient's signs and symptoms when they first start present? If they're coming through their office and they have abdominal or back pain or unexplained weight loss, or would they investigate further if they saw late onset diabetes? We continue as an advocacy organization, and Erin can certainly speak to this as well. Erin, maybe you can chime in. Time and time again, many times these signs and symptoms are being diagnosed. And I know, being one of the founding members of the World Pancreatic Cancer Coalition and being on the steering committee, every year when we're talking about the campaign that we hold on the third Thursday of every year, last year, or this year being yesterday, who do we want to target? Do we want to target the public about the signs and symptoms, or do we make it more specific to the healthcare sector? And it's a hard decision which way to go in terms of that, an early diagnosis and from diagnosis to treatment when that starts. So there's a lot of questions to be answered and looked at, hopefully, as this survey continues to build. We've had it out for about a week. So we won't stop until we get the 500. But I know, Erin, if you can chime in too there.
Yeah, I think a lot of the times too, it's the signs and symptoms that patients experience. It's things that are really common, right? It'll be back pain, or it'll be dark urine, so you think you're dehydrated, or it'll be a stomach ache, so you think you ate something wrong. So I think that that definitely plays a big role in it as well, in terms of people seeking treatment because they obviously don't think it's going to be pancreatic cancer, right? They think it's an upset stomach. So yeah, I think that that's definitely an interesting finding there.
But in
Dr. Leslie?
these experiences are, we did only accept responses from patients that have been diagnosed within the last 3 years. So I'll just make that comment quickly.
That's good. And Dr. Leslie had his hand up.
So yeah, as you've been talking, there's the 2 phases. It's from symptoms to diagnosis that we talked on the last slides, and we need lots of work throughout that whole continuum. And then this one that Jessica talked about, specifically diagnosis to treatment. Ideally, everybody would say we'd like to get started within a month, but you've got to get to the oncologist or to the surgeon, and then the surgeon's got to get you to the operating room. If I see somebody within 2 weeks, I'll say, well, I'll operate with you by 4 weeks. So that's taken 6 weeks from the diagnosis to the OR. And same with an oncologist. If the oncologist can see you within 2 weeks, that's very good. And then to start chemo, depending on if you need a line or not, it's going to be another 2 to 4 weeks. So we would like to get those treatments down quicker, but this doesn't surprise me because I'm thinking, well, if I see the cancer in my male, I hope to have that operation done in 6 weeks. And the oncologist would be the same thing. I want to start chemo within that 6 weeks, see him within 2 weeks, and then get the treatment done within 2 to 4 weeks. And that's just how our system is.
Yeah.
That's also, in a specialized center. Would you agree, Dr. Leslie, that, having that Baker Center?
Correct. We cut it down. And I'll talk about that tomorrow, some tricks to cut it down, but it does come at a cost.
Yeah, absolutely. And I know, it just depends on, the amount of oncologists even at the cancer center, and it looks so different across Canada. I know one of the oncologists that we work with quite closely is saying patients are literally dying waiting to see them. So it's certainly a concerning trend, I think, that everyone's heard about on the news, whether it's pancreatic cancer or not. I certainly, part of our pathways that we'll be working on tomorrow is looking at some of those wait times and maybe looking at some tricks that we can get some of those wait times down. But, patients, and I think that there's some patients here online that maybe can chime in too to talk about their wait time. I know that, in Atlantic Canada, from symptoms to some preliminary data they've pulled, from symptoms to the start of treatment, sometimes can be 11 months from the first time they started addressing the symptoms with a care provider. Yeah. I know I think I saw Ben Perry there. Ben, did I see you there? Did he get bumped out? He would have been a good person to talk about his personal experience. Okay, Jess, do you want to?
Sure.
Oh, just wait here. I see Kathy. Kathy, do you want to share I don't know if you can come off mute and maybe share what you've put there in the chat?
Oops. Sure. Didn't really want to. I love all this conversation, so I don't really want to slow it down by any means. So I'll try to be really brief. I just wanted to kind of, I guess, share my own experience. So my diagnosis, as well as two of my coworkers, were diagnosed in Calgary, Alberta, starting in 2018 and then in 2020, along with myself. And we were all diagnosed by family doctors as having kind of, as a stressful job, IBS, or maybe it's lactose intolerant or whatever, and backache. So all of those symptoms that you're showing in these other surveys is very much relevant. But doctors don't see it still, and this is the frustration. And I was lucky or fortunate for whatever reason because I was eligible for executive reviews, and I really think that if there's a family history, I guess my 2 cents is, I just don't think the cost of an ultrasound is that much. And so if I had not had the ultrasound that I had, I probably wouldn't be here for this conversation. So I'm a 5-year survivor. And I've been told I've been extremely lucky because like everyone else's, was extremely aggressive. But even that, the ultrasound, they didn't tell me that what they found in the ultrasound. I was just told that it would be a good idea to get a CT scan. And so it took a while before I got a CT scan. So time is really critical. I'm a peer support person for people recently diagnosed And there's just too many people that are diagnosed at stage 4. And it's very difficult to have those conversations. So that's kind of my 2 cents. So all this data is relevant. I didn't participate in the survey, but I think it's, I know your numbers are small, but I think probably the results are still going to be very similar for a lot of people. And I would like more to be done because my grandmother had it, my sister died from it, and I have it. So, but even though I had genetic testing, they have not found any indication that it's genetic, but it sure, to me, it looks like a duck and sounds like a duck. I think it's a duck. So, I'd like more to be done for my own children. That's my 2 cents. So stop now.
You touched on an important point, just about the regulatory reform and funding. It always seems that, we are funding in the immediate, the present day, and we're not looking at the burden, the financial burden after a patient is diagnosed. So, for instance, I think it was an IgG4 test. Maybe Dr. Leslie can help with that IG4 test. It was for autoimmune pancreatitis. For instance, there was a patient that we knew that was repeatedly having that test requested, and the lab kept canceling it because of the cost. The cost was $80. But this patient continued to present in the emergency room and would end up in, under supportive care. But you look at the cost of the repeated emergency admissions and the treatment up to a week in hospital, or ordering this test for the cost of $80. So, I think that quite often, in Canada at least, we're constantly looking at the cost, the immediate cost, and not the cost of what it be if we implement what we need to have, to have these patients treated more timely than the burden of it after the disease has advanced. It's one of my biggest concerns.
I absolutely agree with you on that. I'd love to be part of that. But longer defining numbers, because I feel that I'm an auditor, an ex-auditor, so I kind of numbers is my game. But I think that even if you looked at the economic loss of people being productive as workers, right? And then the cost of long-term disability, all of those costs, if they factored that into it as well, right? Because a lot of these, we're not all 60 years of age when we get diagnosed. Nowadays, a lot of people are in their 40s, so kind of at their higher income potential as far as what they can do. And so to me, yeah, I get very frustrated because I just feel that, and it's all provincial, but if provinces started thinking about there's other ways to test this, it would be a lot cheaper, but we could just do on a routine basis, because it's very difficult to identify before we're having, different types of symptoms. Anyways.
Yeah, certainly with those patients that, are at risk. We have Daniel asking, does anyone know why a CA 19.9 is not OHIP covered? I'm not from Ontario, and every province has a different way to cover some costs or not cover the costs. Dr. Leslie, do you know?
Yeah, it's covered in the hospital. So my patients will come to the hospital lab and have it covered. But if it goes to the private life lab, it's not covered.
Okay.
And that's just what they do. PSA is similar. You go to the life lab, you pay for it. But at the hospital, it just gets run. So I bring them into the hospital setting for their lab work.
Yeah, so it's a little different than other provinces as well. Yeah. Is there any other questions before we move on? Yeah, I just see Kathy just responded as well to that question. Okay, Jess.
Okay, so next we're looking at the kind of frequency of different treatment and referrals that are made following a patient's diagnosis. So in our drafted pathways that I'm hoping you've all had a chance to review, it'll be a big part of our morning discussion tomorrow, is determining, what referrals need to be made as soon as a patient is confirmed to be diagnosed with pancreatic cancer. And these referrals can really influence and define the course of treatment and how much supportive care a patient ends up having access to, which can really influence their quality of life as well. So in terms of the types of referrals, medical oncologist seems to be 100% of patients that are diagnosed are referred to a medical oncologist, and that makes sense. A few less percent are referred to a surgeon, and perhaps I don't know what subgroup that would be, perhaps some stage 4 patients. But from my understanding, we've been advocating that every patient should be referred to a surgeon, at least to have a conversation, regardless of stage of disease. And it seems as though so far with our very limited numbers, about 50% of patients that are referred to a surgeon actually receive surgery. I'm sure that number could change a lot, and Dr. Leslie can probably adjust that already off the top of his head. Other than that, something that's come up as really influential in quality of life, as well as efficacy of treating the disease, is pancreatic enzyme replacement therapy. And I think it's widely underestimated. But in terms of the referrals that are made, it seems like about 60% of patients are referred to a dietitian or prescribed PERT, and only about 41% of those patients are actually using or taking advantage of pancreatic enzyme replacement therapy. But we know that this can be a really big factor in getting patients proper nutrition, avoiding that malabsorption that goes with all the digestive issues that are associated with the disease, and can really influence their overall quality of life as well as their longevity. There's some data out there from Dr. Dominguez Munoz that suggested that PERT can be as influential as chemotherapy in determining a patient's progression-free survival time. Another big component of a multidisciplinary care team is social workers and counselors. I think any cancer diagnosis is very heavy, but with this particular disease, where so many are diagnosed so late, these supportive care workers are really critical in helping influence a patient's mindset and outlook, and can really make or break how well their treatment and management can go, as well as their quality of life. So the referrals are definitely important, and the uptake of them actually surprised me at 64% of patients that are referred to these specialists are taking advantage of that treatment and leveraging the support that they can get from that. I kind of anticipated that more patients might brush it off and say, like, I don't need that, or that won't help me. But it seems like it's more well received and more welcome than what I personally expected. Radiation oncologists are much less frequently referred versus the med oncs. But it seems like most patients that are referred to radiation actually do receive radiation. So perhaps it's clear. Again, I'm not a healthcare provider, but maybe it's really easy to determine which patients are most eligible for radiation, and based on that, they're able to make, a very precise decision on who should be referred and who should not be. Palliative care is another one of those. It's like PERT, where we've been recommending for a while that every patient be referred for palliative care, even though there's that stigma around the word. It can sound kind of gloomy, I guess, but we're trying to change that. Palliative care is really just aiming to enhance quality of life and support whatever goals that patient has for themselves. So those referrals are critical, but it seems like only about 50% of our respondents actually received that referral, but as many as like every patient that received the referral ended up receiving palliative care support. So it is important and it's well received by patients. So it's something that we'll definitely continue to advocate for. I don't know if this is time for patients to chime in.
Yeah, I will say that in 2023, when we had our National Pancreas Conference, palliative care was a big topic of discussion as well. And we also know, many of the specialists from around Canada spoke to the burden that the palliative care referral system had. And, we've had a few conversations with medical oncologists around Canada, about the question. It's even in the education system, it's in the healthcare system. Do you continue to refer when you know that they're already overburdened and can't take those referrals? And I'm saying yes, because we need that data of the referrals. We need to know how many patients are being referred and how many don't get to palliative care, and for that palliative care support, so that we as an advocacy organization can also discuss that, you know. So, it'll be interesting to see what this data shows when we have collected those 500 responses. I have a feeling that won't stay. That number will change quite a bit. I know that, palliative care in every province looks very different. And I know a few provinces off the top of my head that are just overburdened. They can't take the patients that they need to take onto their caseload, but it's such an important part of a patient's support to be referred to palliative care, whether they stay on palliative care or they just use it for the time they need it, and then they're discharged from palliative care as well. We also had a huge, with Valerie, one of our presenters in 2023, a huge discussion about palliative care in the United States is now being called supportive care. But in Canada, they've had that discussion and they really want, it's semantics, and they really want to keep that palliative care title just for the pure definition of what palliative care offers to their families. I don't know if there's anyone else that wants to chime in there. We have a quiet crowd. Usually with patients, the patient group, sometimes our groups will go on for hours. Okay, Jess, you want to move on? And I'll just keep looking for hands, and Julian's there as well. I just did want to say one other thing. We have a couple of other people that have spoken in the chat that I'll speak to, but I did put in the PERT calculator. So we launched that 2 years ago, and the PERT calculator is being used by thousands of people from around the world. We've had some great feedback. It is licensed through Health Canada, and was funded by an unrestricted grant through Viatris, which we were very grateful for. We now reissued a new platform. So we did a survey to our users. We had, at that time, I think 1,500 or 1,800 users, completely did a survey, took their feedback, listed, I think, an additional 63 foods. Poppy Casvis was a huge supporter in helping us with our calculations on the PERT calculator. It also is, PERT is so vital, but at the same time, many patients are, being prescribed 3 in the morning, 3 at lunch, 3 at supper. So, certainly there's a lot more advocacy that we need to do as an organization to the pharmacy group. Sometimes we're hearing from patients and from physicians too that the pharmacists are pushing back in terms of the amount that's calculated for that patient in terms of meals and fat content and the patient's weight. So still a lot more work to be done in the PERT area as well, not only in getting that treatment, but also educating, on how to write a script and for the pharmacists to understand the amounts that that are being prescribed to patients. We have Daniel, who was speaking, and he said, I'm in Ontario as well. I had a Whipple and chemo last year, but continue to have my blood work done every month. So at the hospital. So I think Daniel's talking about the CA19-9. Daniel, is there anything else you wanted to say as part of this discussion that I'm missing, or no, you're okay? No? Okay.
All right, so moving on to something that seems like a big up and coming and, is becoming more well adopted, is genetic testing and molecular profiling as part of that early steps after a patient is diagnosed. Most patients seem to be not aware of their genetic markers ahead of diagnosis, and that's not too surprising to me. But 62% of patients were able to complete genetic testing either before or most often following their diagnosis. And if we break that down by province, it seems like we might be doing a little bit better on the eastern side than out west. I'm not sure if that's accurate or if those numbers will completely shift when we obtain more responses. Can anyone speak to that? Or
I did hear a rumor. I did hear that molecular profiling is now covered in Ontario. Can anyone speak to that?
Yeah,
I
that
know.
is true. Oh, sorry, go ahead.
That's okay. You go ahead.
Yeah, I just heard that actually from Cancer Care Ontario. They were molecular profiling is covered for certain number of markers, not like a whole whole genome sequencing or anything, but and hopefully other provinces will follow suit. I was actually just asking about this slide in terms of, is this a germline only, this genetic testing that's on the slide, or is it a
Yes.
combination? Do you know? It's just germline? Okay.
Yes.
So that's fantastic. So how did you find out about it? Was there a press release or?
There was, I think it was October, I was speaking to an oncologist also at Princess Margaret, and we just at Pancreatic Cancer Canada, we've really been passionate about genomic sequencing for patients with pancreas cancer because it's really only through certain research studies and obviously more accessible in like Ontario and Quebec, maybe BC. So I've just been keeping my eye on the research, but it's it's pretty new.
Yeah, I know that CCRAN's Philomena's been doing a lot of work, in terms of research and collecting data and pushing for molecular profiling. So I'm not even sure if she's aware of Ontario. So I was looking for a little bit more information on that. So that's good to hear because once one province starts to do it, it's a lot easier for advocacy organizations to push for that in the other provinces. We do know that when we were working with PanCan in the States, Up until maybe 4 years ago, they were allowing Canadians to have molecular profiling and covering the costs of it. But it got to the point that, and you look at the difference in population, so 37 million in Canada and 360 million or whatnot in the United States, and the same amount of referrals were coming in from Canada as were coming in from the United States to PanCan for molecular profiling. So it speaks to the amount of people that are certainly interested in having it done. So I'm excited about that. I'm excited about that. Chris, you have your hand up?
Yeah, so just for information, I'm a researcher here at Western, and I'm one of the leads in the Baker Center for Pancreatic Cancer. And to speak to that, it's yeah, they're basically it's either just happened or it's happening where they're handing it over to the province to do the testing, and it's going to be somatic because they're going to be looking at the mutations of the actual tumors. Yeah, and so the province is taking that on.
That's excellent. Do you know if there was anyone, like, how that came about, Chris? Like, do you know if there was a lead pushing that to make that happen? Like, it didn't happen.
No, I think it's the province decided that. Ken, I don't know if you can speak to this any better than I can. I do know that, we had been offering that through a private donation prior to this, and now we don't have to worry about that. So I think it was probably pushed by several different centers in the province.
That's great. That's great to know. Sarah, you have your hand up?
Hi, I have a question. I had genetic testing, but I had genetic testing that was free of 12 genes. And then I had genetic testing of 324 genes that was not free that I paid for, or my plan did. And I'm just wondering, what are you referring to when you say genetic testing?
Um,
Jeff?
Your EGFR, right?
Yeah, yeah. Did you understand my question?
Jess?
I do understand your question. I'm just wondering, I don't think our survey question specified. So like the question asked, like if you underwent any germline testing.
Okay.
So I think it would include patients that had a small panel taken as well as those that had a more comprehensive.
The reason I'm saying that is because it was only because of the 324 genes testing that I was able to have a visit with Ken Leslie and Dr. Bredner in London and go on I had an EGFR 19 deletion that was in both my pancreas and my lungs, and I was able to get a Simranatib as a drug, which is for exactly that, and it has been very good for me. And it would never have happened without genetic testing of the 324 genes, which covered that.
Right, that's interesting because that's probably a detail that a lot of patients wouldn't know to ask. Like if their doctor's referring them for a genetic test, they're just going to go for that genetic test. And I don't know how many people would think to say, well, how complete will this test be?
The genetic testing of the 12 genes, my father died of pancreatic cancer 30 years ago, and it said that I did not have the hereditary gene. However, I had a hard time believing that. And I wanted to go further. I was actually dealing with Sloan Kettering on having a report from them, and they recommended genetic testing. And that's why I decided to go ahead and do that. But it wasn't until Ken Leslie looked at the genetic testing report that I got further treatment.
Right. So it seems like there's a lot of like self-advocacy going on, which is great for the people that have the information at hand to kind of stand up and demand what they would like to see in terms of their course of diagnostic tests. But it's something that I don't think we should be so reliant on in terms of influencing the care that patients receive.
Mm. We have a question here from Keen Sung. Is there a comparison with care in the US states? I haven't, like, I certainly have seen, and this is, certainly one of the reasons why we're doing this. This has never been done in Canada. We've never, surveyed on a national level a patient's, pancreatic journey from diagnosis onward. Um, I haven't read a comparison. I certainly have seen studies in both countries. I haven't seen a comprehensive one in Canada, and I can't say I've seen a comprehensive one in the United States. That doesn't mean it's not there. I don't know if anyone else can speak to that, but I haven't. We certainly see, um, not specific to each of the states that are in the United States. And as I said, I've seen studies that have come out of Nova Scotia, Ontario, and Alberta, when they were looking at translational research and the patients going through some of the pancreatic cancer journey, but not the whole journey. Jess, you've done a lot of research in terms of the landscape. I just haven't seen. I haven't seen anything.
I think there's some people with their hands raised if they can chime in.
Go ahead, Ken, you can go first.
Okay. The states is quite variable because it all depends if you have coverage or not.
Mm.
And they've got lots of, Sloan Kettering, if you've got money to go there, it's fantastic. But if you don't have money, you're not there. So it depends if you're looking at population versus just a system that you can get into. So across Canada, the publicly funded system for everybody's better than the states across the country. But the reality is there are some really high-end programs that can get done things really quickly, much better than our timelines, and they can do whole genome sequencing, but you need your Visa card. So it's comparing us to the states wouldn't be right. Be more like you're going to try to compare us to a European country or Australia, somewhere that has a public funded system, though even, you look at Britain, they've got a pay and private system. So Canada's kind of still unique of having a single payer.
And I think, again, it comes down to, certainly we'll be talking a lot about it. Tomorrow is, even accessing within Canada an equitable healthcare system, because we have so many challenges within Canada, getting to the different treatment centers. Chris, you had your hand up?
Yeah, so just to follow up on what Ken was saying, I work with some researchers in Michigan, in Ann Arbor, and they've done an analysis of care delivery and outcomes. And the biggest factor that they see is really how close they are to Ann Arbor. So if you can get to Ann Arbor and University of Michigan, it's great. You get much better outcomes. But if you go to a rural hospital in the middle of the state, you end up getting a much worse prognosis and worse outcome. So that kind of data is out there, and I suspect that it's very state to state as opposed to across the states.
Yeah, absolutely. Any other questions before we move on? No? Okay, Jess.
And then we probed the frequency of molecular profiling uptake. And across the provinces, it seems quite comparable, again, with our very limited data set of about 50% of patients being offered molecular profiling. And that would be at the tumor level. Alberta, BC, and Ontario have about that 50% frequency. And so far, just one of our 7 Nova Scotian respondents have reported being offered molecular profiling. But again, that's a very small sample size, and it could all come out in the wash by the time we reach our goal of 500. In terms of the findings from these molecular profiling tests, most of the patients that underwent molecular profiling, 67%, actually received significant findings that were able to influence their decisions in determining their course of treatment. And those all spanned different results, including the ones listed at the right there. Does anyone want to comment on?
Can I jump in there, Jess, for one thing for that one slide? So this is, as an advocacy organization, is where I really struggle, because I guess my concern is, and not that I'm saying stop molecular profiling or genomic testing, but my struggle is, and that's why we're having the first discussion tomorrow about driving change, is what we can do in preparation of more and more patients going through these tests and the profiling, how we can advocate for their treatment, the funding for their treatment, if they are found to have certain mutations that can be treated other than the standard way for pancreatic cancer that's covered. And that's certainly a discussion we've had with CCRAN, as well as, and the different cancer centers, will speak to it tomorrow. But that's my biggest fear, is that, the patients, they may find that they have certain mutations, but can they always get their treatment covered? Especially if they're in this very low percentage group. I know that even working with industry partners, there's certainly a frustration in Canada is to get the drug approval for funding, even if they've been, recommended by Health Canada for treatment. That's probably one of the biggest areas I find scary. Okay, Jess, you can.
It's just a question in the chat there from Stephanie.
Oh, sorry. So Stephanie is asking, is there evidence that suggests genetic testing and molecular profiling improve outcomes? Aren't treatments for PDAC limited to 2 standard chemotherapies regardless of these test results? Interested in the significant findings data. So I would say yes, Stephanie, and the physicians can also speak to this that are in the group, the specialists. But yes, the whole point behind molecular profiling and all the work we're doing for individualized treatment and care is that we don't no longer treat pancreatic cancer as one disease. Is that, well, it's one disease, but we don't treat it the same way for every person. So every person is their own individual, and if they have certain mutations that other drugs would treat better and provide them with a better quality of life, or a longer life, or we're looking at certainly cures. Yes, I think that the genetic testing and molecular profiling is something that we're all quite passionate about, because it does provide patients with better outcomes if they can find, certain mutations that a person may have. Chris has his hand up.
Yeah, to speak to that a little bit, if a patient is identified with there's a few mutations that they immediately will be put on a different type of drug. So I think BRCA1 and 2 mutations are examples of that. The second thing is that we're finding more and more that maybe the molecular profile might indicate which of the 2 drugs they might respond to better. So that's an important aspect of what's going on. And then third of all, there's now in clinical trials inhibitors for different types of KRAS mutations. And so knowing which mutation it is might allow that patient to be treated with something more specific. So obviously I'm a scientist, I'm not a clinician, and I'm not a patient. But I would argue that I think it's important to do this kind of molecular testing, and the more you do, the more we understand about the tumor that might be helpful.
Yeah. And helpful not just for the individual, but, for everyone that's will be moving forward impacted by pancreatic cancer. Kathy was asking, what is the turnaround? And I guess, if the center, so I'm not sure what the turnaround will be in Ontario now, but I know if the cancer center's offering it, the turnaround, and if you're paying for it, like through PanCan, I think the turnaround was 3 weeks. Erin, would that be correct?
I think it was something like that. Yeah, about a month.
Yeah, so I think, and people can speak up and correct me, but I would be thinking around 3 weeks. And I think that that's what Dr. Zagopoulos, I would even say shorter than that at McGill, if I remember correctly. Okay, I think we can move on. I don't see any other questions up.
I have a question, and it might be a naive one, so forgive me. But out of curiosity, is there any benefit to choosing germline testing over molecular profiling, or is it a matter of one is more accessible or less costly than the other? Because it seems like the molecular profiling data would be more informative in terms of um, determining the course of action that's taken. Am I on the right track there, or
Just waiting to see if Ken was going to answer this because he's the clinician in the room. I'm not. I, I will say that it's the molecular profiling done on the tumor is going to be more informative if you're comparing the two.
mhm,
I would argue that for a really good analysis, we should do both
okay.
because you'll get information in both. And this sometimes allows us to see what may have caused the cancer or caused the progression versus what's just the result of having the cancer. So yeah, I would argue both, but at the same time, I would say that if you're going to say one, you'd go with the molecular testing of the tumor.
Okay, interesting. Thank you.
I also see Eilert has her hand up. I hope I
Yeah,
pronounced your name right. Eilert?
oh, it's Ayelet. That's okay. Um, I think as well, just an important point in terms of the germline is how it can also inform screening, obviously not for pancreas because we don't yet have a clinical screening protocol per se, but just how it can inform screening for other cancers, for like if someone has a BRCA2 mutation or for Lynch or whatever is found, it can help inform screening for other family members. So I know in certain provinces the guidelines are for every incident or every patient that comes in with pancreas cancer, it's for them to have germline genetic testing, and then of course molecular somatic testing is important to help determine what treatments work best. And I think that was the past one study was just brought up about the two first line treatments, what would be better depending on a biomarker. So, but they're definitely complementary.
Yeah. I don't know. I see Lee here in the participants. Lee, is there anything you can add to that? I'm going to throw her right under. She's just had some surgery.
Also, Steph, Floria commented in the chat if you want to check that out.
Okay. So in BC, the oncologists do not advise molecular testing of the tumor unless a reoccurrence has occurred. Do you want to speak a little bit more to that, Floria?
Sure. I'm a patient and I'm also a physician. So when I asked about, the foundation one testing, which is the molecular testing, I assume, my oncologist basically said, no, don't even think about that. Don't waste your money on it until you actually have a recurrence. And that was the advice that I got. So I am just sharing this experience, and I'm not sure, like in other provinces, what their protocol is, or if there is one.
Yeah. Yeah.
I wouldn't think recurrence would be a very frequent incidence in pancreas cancer. Like for a patient to be kind of in remission and then have it recur, sounds like it would be a rare finding, but I could be wrong.
Yeah. Violet has her hand up.
Yeah, I was going to say, so just based on my experience, and again, it's through research, that if someone had surgery, then part of that would be profiled. But we did learn that the mutations found in recurrences could differ from those found at surgery. And I think that could be more informative, and perhaps that's what she means by kind of not really wasting time profiling, but it's if you have profiling first before surgery, or then it may not necessarily mean that you don't need to have it at recurrence, because there could be different findings at that point. I'm not sure, but I'm just trying to see if that's perhaps what she means by that.
We have Ken, and then we have Sherry.
So the genetics and the molecular profiling is just going to get more and more as we mature, and it's going to become standard of care. Not just 12. You're going to have whole genome sequencing of the primary cancer, the metastatic cancer, and we're going to learn what drugs react to the best of them. And that's going to take a while to get through, but Ontario is doing it for more of their cancers, the molecular testing. They're not doing 120 genes, or they're not doing whole gene, but as you do more of it and the costs come down and the benefits are showing that you have something, that's where we're heading, because we just can't stick with the standard chemo. We've got to evolve into all these new areas, and we've got to figure that stuff out, and it's coming. We did genomic testing at the Baker as a study, and everybody got it, and because it was important, and it does affect a few people, but other ones it doesn't. But as you look more, you'll find more. So Ontario started for a lot of cancers genomic testing, and it's just going to keep evolving across as we get more knowledgeable. So it will come down the road for sure.
I think that's why, conferences like this are so important, though, too. It's a collaboration and figuring out where these gaps are, and the challenges, and, setting, some recommendations ahead in the next year and a half that organizations can work on together, to ensure that we're working with the healthcare professionals and industry and the patients and their caregivers and other advocacy organizations to really push. So when I hear Ontario is now funding this for pancreatic cancer patients, it's one more thing that we know that we can go out and push. Sherry, do you want to? You can unmute yourself.
Trying. My experience. My experience was, well, I guess 2.5 years ago, I had my molecular, I can't say it because my tongue, profiling done through Pancreatic Canada, and they sent it to the States. And what came out of that, I was in my second treatment of Fulfenox, and they found out my gene mutation was PALB2, and I was recommended the gemcitabine instead of the fulfinox. So that's one of, I guess, like they said, they can better treat you if they know,
Yeah.
if they know your gene mutation or what your tumor is made out of. But I didn't get, it was my oncologist, my surgeon didn't send it away, but it was my oncologist finally said to me, have you been sent away for testing your tumor? And I said, no. And that was a year and a half into it. So who knows? Like, I know I have more time in between my cancer treatments than I did before. So
Yeah.
who knows if it's working better or not, but I'm 4 years in now. So
That's wonderful. Yeah. And I think that that's, the biggest takeaway is that, getting these individualized treatments, I think, is going to change, the landscape, as it won't be tomorrow, but it's coming. There's so much exciting research. When we started this work 19 years ago, there really wasn't anything. And when I look at the pancreatic cancer landscape in Canada for research, there's a lot of hard work and a lot of exciting opportunities. Poor Lee, she's still feeling, she's in recovery, but she says from a researcher's perspective, I think germline should be offered to all pancreatic cancer patients, regardless of postal code. Tumor molecular profiling should also be promoted, especially advanced diseases, because it finds actionable alterations, that can guide clinical trial options. Thanks, Lee. I know that you're still in recovery, but thanks for chiming in there.
I was just going to ask, like, now that molecular profiling is covered for patients in Ontario, does anyone know how early it's implemented in a patient's kind of trajectory? Is it standard to start first line treatment and kind of exhaust that and then turn to molecular profiling to see if we can do better, or is it step one?
Chris?
So here, what happens is when a person goes in and has an endoscopy, even before diagnosis, we take a sample and we basically start the process there. I know that locally it's taken us a little longer than 3 weeks to get the results. And usually, I think the average was between 5 and 6 weeks. So generally we would start the process, and then treatment would probably occur because we didn't want to wait. Again, I think it varies based on patient, but again, I'll let Ken correct me if I'm wrong on that.
Yeah, it starts when they get a sample of the tumor, and that gets sent away. And the hope is that it's going to be kind of in that 3-4 week range as the labs get better at it. They're not at every lab. They're going to be just special cancer center labs that are going to be doing it. So the major teaching hospitals, so they'll be processing it. So those will get quicker. But as Chris said, right now it's about 6 weeks, but that's okay. It's going to get faster. But they're not testing 120 or whole genome yet.
But they're able to start some type of treatment in that lag time.
Correct.
And then if something more promising comes up from the results, then they can switch.
Correct.
Okay, that makes sense.
That's fantastic. Okay, Jess, do you want to? I think I'm just looking for hands. I think we're okay, and we're doing great with time. So we're looking at.
Yeah, sounds good.
Okay.
The last section of the survey was a bit more open-ended for patients, and I think is even more of a discussion opportunity than what we've talked about so far, and that is the factors that kind of determine a patient's journey or their experience, and what they value the most in terms of access to treatment, communication, speed, of those types of variables that can affect their care journey. And it seems from the numbers we've collected so far that the top 3 priorities of patients are getting that elapsed time down from, complaining of symptoms to getting a diagnosis to starting treatment. We also had a very open-ended question that was, what has gone well for you so far, and what has not gone well? Like, what has been your big pain point? And the most common complaint, I'll call it, is the delay times between receiving treatments, etc. And so it seems like as a community of people trying to support these patients, anything we can do to get those delay times minimized, as well as offering them clear communication and making treatment as accessible to them as possible. And that might mean different things for different patients in terms of assisting with travel to finances, you name it. The factors that could limit someone's access to treatment could vary person to person depending on their circumstances. But this was kind of the slide that I'm hoping to hear more open-ended stories from patients in terms of what they've been satisfied with versus what has really made the journey more difficult than it already is.
It makes when we have our and Erin, you can speak up, and any of Erin's patients that come to the Peers with Pancreatic Cancer that meet every Monday night, with delays comes a lot of uncertainty, for patients. So I know that when we're counseling patients, when patients, have their highest stress level comes from the uncertainty. When do they start treatment? When do they have surgery? What is the recovery like? What will chemo be like? And usually through, our experiences, we've seen that when there's a plan in place, and treatment has started, whatever that looks like, we know that their stress levels go down quite a bit. But if there's patients in this group, or Erin, maybe you can just start to discuss, since you're with those patients every Monday night, if you can speak to a little bit more of that, and we'll have some patients jump in if they feel comfortable.
Yeah, definitely. I think the thing that we hear the most is definitely the speedy access to treatment. People are being diagnosed and then being told it's 8 weeks to see an oncologist, or it's 4 weeks to see an oncologist, and they're anxious because they know they need to get a port put in, and they know that they're going to have these treatments coming up and things. So that's definitely a really important part. And again, seeing communication right at the same level as access to treatment, like, rings really true. I've heard a lot of experiences from patients with just being able to have those conversations with their doctor and being comfortable to have those conversations. And I think, like, finding the right physician for you and the right person to provide you care. Everybody needs something a little bit different. So just, yeah, I think that these totally make sense. They they definitely correlate, like proximity. People are pretty willing to travel where they need to go, despite it being, a financial difficulty. There's so many layers to it.
I know that the oncologist, it was Dr. Welsh was saying that there was, when we were looking at, we've had a great success with registrations for this conference, and what we were targeting. But I think they were saying that there was 800 medical oncologists in Canada. And if you look at the population of Canada, and looking at the numbers of how many Canadians will be diagnosed with a form of cancer at some point in their lifetime, that's overwhelming. So even communication, I know many medical oncologists from across Canada have spoken to me about how limited they feel in terms of being able to, deliver the diagnosis. When people hear pancreatic cancer, they're scared as hell, just because of all the stigmas we're fighting as well. And then their appointment's over. Many, and then it's hard to have, additional time. So I think that, being able to work with the cancer centers as close as we can to improve those communication avenues so that they don't just have the medical oncologists or the nurses that are already overburdened, but they have other avenues to ask those questions and get that reassurance from other patients. So Erin runs a group where it's just patients every Monday night. And Erin, you usually have about 30 something registrations.
Yeah, usually we have a turnout of around 15 people, 15 to 20, and then we have more people that register. Yeah.
Yeah. And then you have, all those patients, supporting each other, offering advice, answering each other's questions as best as they can. And having you there, certainly helps with the communication, but to hear a diagnosis of pancreatic cancer and then, to have to wait for the treatment and have those meetings, we know that the time is limited. So it makes that diagnosis and the understanding of the disease all that more limited.
Yeah. Something else I think could be on here too would be like hope. I think patients value hope from their oncologist. They don't want to hear, "Oh, just go home and get your things in order, get your affairs in order." They want to be
Yeah.
given the chance. They want to be the opportunity to be that outlier. So I think that that's like another really big patient value is give them the opportunity and let them try the treatment. Let them if it's safe, obviously. Um, I think that's another really big thing.
We have Keen Sung.
Hi. I don't know. I haven't used Zoom on mobile for a while. Can you all hear me?
Yes.
Oh, okay, great. Yeah, I'm a caretaker. My dad passed in 2024, but I just wanted to share three things, I think, in terms of experiences and learnings. I think one, Aaron's group is great. It was super valuable. I had both free and paid support that I was going after, but I think by far Aaron's like the group that's run on Mondays was the most supportive and the most helpful as a caretaker. So I just want to point that out. The second thing, I think two things that I want to kind of share. One of the things that put our piece of that I guess gave it's not really comfort or peace of mind, but kind of moved us forward in our journey the most was a 15-minute conversation that I was given from a medical oncologist after weeks of not being able to speak to one, and that was after some pseudo threats that I made to the hospital. Definitely like sort of a pejorative, sorry, but like daughter from California syndrome that I had. But like the 15 minutes was highly valuable. So I want that sort of, I guess, on the record as like something that I think was like, I know medics are super busy and stuff, but just like having that line of communication, I think is super important, even if it's just for 15 minutes. The second thing that I thought that I'm fairly passionate now that I want to see changing is actually better support in terms of helping a patient through goals of care and basically what the family and what the patient would want once they're no longer able to make decisions for themselves. The support that we were given boils down to any goals of care, or I think Alberta is called goals of care. I don't know where it is, what it's called elsewhere, but like it boils down to basically a one-page PDF, right? And I don't think that's enough. I think there are a lot of other questions that need to be asked and explored when the patient's still able to make decisions. So that's something that I think needs some attention. So yeah, that's my airtime. So that's all I want to say.
No, great points. It goes back to, that equitable healthcare. What does that look like in every hospital, with a patient that's been newly diagnosed with pancreatic cancer? How can we get those standards, delivered in all the cancer centers? So, certainly all this feedback, is important. Sherry, you have your hand up? Oh, I think you're on mute, Sherry. Oh, I don't know. Sherry, did you hear? You're on. Do you want to
There I
unmute?
go. I'm just trying to plug myself in because my battery's dying and my plug came out of the socket there. There we go.
No worries.
Hopefully I won't lose you or you lose me. Yeah, I was to speaking to what Aaron was saying is we want more hope. Like I've just so much negativity along the way. It was like if I hadn't gone to a surgeon first, that was the one first right thing my doctor, my family physician did. Is after I had an ultrasound, a CT, and then a gynecologist told my doctor to rush the MRI, which they thought could wait. It wasn't urgent. And I was referred to the surgeon. I had biopsy, but they said it was negative. I kept having severe symptoms for 2 months. It was getting worse. They did some blood work. I was rushed back into the surgeon and he did another biopsy and I was 4th-stage metastases by that point. Now my surgeon, though, if I hadn't gone to him first, I'd probably be dead by now because the oncologist said I shouldn't be having surgery. The surgeon did the surgery, even though he said he couldn't cure me. He said he was going to give me quality of life, and he said 2 to 5 years. Oncology said 1 year.
Yeah.
But even when I went for my, I'm upset, and I'd be crying, and the doctor at the hospital where I'm having my treatments, and she'd be saying like she couldn't figure, like looking at me like I shouldn't be, like, do you have somebody to come with you? Are you getting your affairs in order? This is, the outcome of this, don't you? And I'm going, yes, but just can't anybody say, let's fight this? Like, let's see what we can do,
Yeah.
So yes, that's a big thing. Yeah.
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 And when you were talking about palliative care, my family doctor, she said, I got the form to change over to palliative care doctor, but she goes, I don't think we're there yet, which this was maybe a year and a half, 2 years ago. And I said, no, maybe not. And she said, I can look after you right now. And so that's where I'm at. But I ended up want to tell everybody, I joined a palliative care support group through Hospice Wellington in my area. And it's been wonderful. The only downfall is a lot of the members, there's, we lose people, right? But it's very supportive. And if you need any help with anything, you have any questions, if they don't know, they will find it. So that's something, I just wanted to put out there, that's what I'm part of this group, and it's been great. Yeah.
I think, there's a lot of stigma still attached to palliative care, as Valerie was talking about in our 2023 conference. And, I think people need to understand it is a specialized medical team, that provides physical, emotional, and spiritual support, living with chronic and serious illnesses. So she's also had patients that have been referred to palliative care that may come off it later on. It does provide both the patients and the families with additional support that they need, and a team around them, which is quite often very challenging for patients to build. If they're at a cancer center where maybe the care is more involved in silos, so maybe those specialists that should be around that person aren't working necessarily or communicating together. Ben, do you want to ask your question? Can we ask about Ben? Do you want to? You've been
Sure.
so quiet, Ben.
Yeah, I know. I think so. Hi, folks. Those of you who don't know me, I was a stage 4 with no hope back in November of 21, and we did some adjunctive therapy, and we didn't tell our doctor, And when we read the files recently, my report, and it had said that if the patient is talking about taking this, we suggested no. If they take it and there's any negative side effects, we'll be taking them off chemo. But there was positive side effects, and it shrunk the lesions on my liver, and the tumor disappeared, and they didn't know what happened. And they could say, and I have no problem with my oncologist whatsoever. I think it was wonderful. Like, and I do understand that the hands are tied, handcuffed, whatever you want to call it. But yeah, I got great positive results, and it was said that whatever I don't know what you're doing, but keep doing what you're doing. Then the surgeon said, Mr. Perry, I honestly never ever expected to see you in here again. So and the chemo for me didn't start until it was November. They said you're stage 4. I didn't get chemo until mid-January. My first day in getting chemo, there's a guy sitting across from me who has this rare form of brain cancer, and he said he was diagnosed on a Monday and received chemo treatment and radiation on that same week on Thursday. And why does it take so long for pancreatic cancer? And I can guarantee you every patient here feels the same way, that they look at us and they feel that you're a walking dead cancer, and they don't. And in a way, we all kind of see it the same way. That do we want to spend the money on someone who's probably going to die in less than a year anyway? And that's how we feel, and that's what makes it so hard to have hope, because that's how we all feel. So that June of 22, so what's 6-7 months later, I had surgery, and still it's this week that they said that, get your affairs in order, 4 years ago, and I'm still no evidence of disease. So we were forced to try something different outside the box, because we know how bad the results are. 3% stage 4, make it 5 years. I'm at 4 years, and my cancer counts are 2, and the highest they went since surgery was 7. So, and I know myself, and Stephanie and everybody here who knows me, I go to these groups to let people know that there are people who get through this. There is hope, but and we know that there's stats out there that a lot of the people who are doing well have reached out for something different, and to look into something different. But the doctors are telling us, if you try anything outside of standard of care, we're going to cut you off. And it's a hard pill to swallow. So I don't want to go on and on about this, but and I know there's a lot of other people here who stand beside me, behind me, and that's all.
Yeah. Yeah. We know that about 81% of patients, any cancer patients, do look at what else. That's it's an important part of the conversation. Jane found her hand.
I did.
Jane, I'm just going to, we're a little bit over time, so not to rush you, Jane, but we'll start wrapping up just in the interest of time, because we have an early morning start as well. So Jane, no rush, but I just wanted to let everyone know I have my eye on the time there.
All right, I'll be quick.
Thanks.
So I was okay, no worries. I was diagnosed in 2023, and I was a stage 2. But my symptoms were for years, I think, prior to my diagnosis. I agree with the access to treatment, that is absolutely mandatory for us as patients, with the timeline and going like how quickly we can go from a stage 2 to 3 to a 4, and for a possible surgery and cure to a not great outcome. And I think the access to treatment, and I think that these clinicians need to be a little bit more empathetic to our cause when that panic sets in, that we know what pancreatic cancer is, the statistics of pancreatic cancer. Anybody that knows that I have cancer in my pancreas, I get a response like, oh, oh, sorry. You know, it's not like it's an easy diagnosis to take. So I think uh, with this access to treatment that it's absolutely essential. And just continuing on from what Ben had said as well, I do agree that with these horrible statistics, and they have not really been that much, that much improvement over the last 20 or 30 years. I mean, there's still horrible statistics. And it doesn't matter, like like the treatments they're saying are exciting, and that this is coming down the pipe, that's coming down the pipe. People are still dying. We're still dying from it at a very early, early diagnosis on. And when we look at alternative treatments, I think that should be a little bit received a little bit better. Same situation happened with me, because I did take a lot of I sought treatment from anybody that would listen to me, anybody that would talk to me about it. And I took their advice, and I took their treatments, and I did anything that I could possibly do to increase my chances of survival here. Because, chemotherapy, yes, I did take chemotherapy, I did have surgery, but, those statistics were still very, very grave in the end. And when I talked to my oncologist about, the potential for an alternative medication, like an off-label drug that I've read lots of research on, maybe not conclusive at this point, but who's going to do research on metformin for pancreas cancer when, it's been researched to death and there's no money in it? So when I had asked, it wasn't about metformin, but for another drug, my medical oncologist said, absolutely not. Absolutely not. No, no, no. It does not work, Jane. These treatments, I don't know why. And he was very adamant about that. And I really liked my medical oncologist as well. He did great things for me. But in the end, it was he said, absolutely not. And then when I carried that forward to my family doctor, she said, I will never prescribe this for you. Never. We are evidence-based practice. There is no evidence. I will never order this for you. And I'm left with, great, thank you. I'm fighting for my life. It's my life I'm fighting for, and to be told I will never order this for you, it doesn't sit very, it's very, I feel like there needs to be more empathy for sure from clinicians. And that's my spiel.
Well, thank you, Jane. It's really hard for, I speak to some of the, for some of the oncologists that I've spoken to, and Ben, I have had a lot of discussions too, that it's so hard to put evidence-based practice against something that's not as evidence-based, and to, find a way for both groups to work together for the patient's benefit. And I see one hand up here. Jillian, can you see? Oh, there I have. Oh no, I think maybe that's the only hand. But I will. There was a meeting I had with a medical oncologist, and he said, and this goes to your empathy, Jane. And he said, I had a patient in today. They're dying of pancreatic cancer, and their biggest topic of conversation, like their biggest need for the day, is a infected, painful, ingrown toenail. And he knew that was the immediate need of that patient, because they were in pain. They couldn't wear their shoe. It was infected. And, and then we look at that number of 800 medical oncologists for what, 15 million people. Like it's just, it's so hard, for the healthcare teams. I know that they're struggling to be able to spend the time with the patients that they need to. It's and I think that, finding these partnerships, in a way to move forward, and, again, hopefully we can move, we can have further discussions about this with the healthcare professionals tomorrow on our pathways to diagnosis. And I think Lori's here on the call as well. It was a big passion of hers, is trying to figure out a way that we can have all these partnerships work for an equitable healthcare experience for the patients, such as yourself, Jane. Yeah. So we are 20 minutes over time. I promised myself I wouldn't let that happen, but I certainly didn't want to shut down some really important discussions as well. So I want to thank everyone for coming tonight. I know that sometimes, everyone is so busy, they're working. So to spend an extra hour and a half with us tonight, we really appreciate it. We certainly appreciate all the insights that were shared. This is recorded, and this will be part of our paper, our conference paper that gets published. So we've heard all of you and appreciate the feedback that we've received. If you are a patient and caregiver, I've put the link into the chat. Please, 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 please fill out that survey, and other patients and caregivers. Please make sure that you pass this survey on to them. We really would love to have 250 patients and 250 caregivers as our goal. So, any support you can provide in passing out that link, we'd greatly appreciate it. So I want to thank everyone. If you are in person tomorrow at the conference, the breakfast starts at 7:30. And we'll see you all there. And I want to thank everyone for coming. Thank you so much. Thanks, everybody. Take care. Have a good night.
Thanks,
Bye-bye.
everyone.
Thank you.